I'd like to thank Dr. Tedeschi for inviting me to present here and for all the support he's given me in my research. And I'd like to thank you for not walking out after the master has spoken. And this is what I'll be talking to you about. I'll be talking to you about post-traumatic growth in husbands of women with breast cancer. The data that I'm presenting here is a subset of data that we have accumulated in a study during you. So I don't have to convince you that post-traumatic growth is a valuable experience to look at, and I don't have to encounter the resistance that I encountered at the beginning when I spoke about, for example, people who recovered from heart attack, and I would get the response, oh, heart attack is a good thing, you want me to go out and get a heart attack? Well, that's not what we're talking about. We do know that post-traumatic growth occurs in a large proportion of people after a large variety of traumas. So what I will focus on here is really who are the people that are likely to experience post-traumatic growth, or if you see first, and I think Rich made it very clear, post-traumatic growth is the outcome of the processing of the trauma. The more one thinks about, talks about, writes about the trauma and its meaning, the more likely one is to perceive benefits. So what we will look at is which are the factors that influence this cognitive processing that makes it possible for people to sustain this very painful experience and come out on the other side with a sense of gain from the pain. And the three sets of variables, as Rich indicated in his model, are event-related characteristics such as severity of the event, individual characteristics such as optimism, and Joel will talk a little bit about some of these individual characteristics, and the social context characteristics will be the focus of my talk. We know that the social context is relevant to trauma. Dan Meichenbaum did it very well this morning, talking about the recovery environment and making it very clear that the outcome of trauma is very much related to the social context that the person after the trauma goes through. But we have conflicting data as to which aspects of the social context are really relevant. So I'll talk about that. But first, I'll tell you that I chose to look at the social context after trauma in
it's like a mirror trace.
Yeah, it really isn't staying where it should be. Okay. I chose to look at it in the context of breast cancer. It is now clear that breast cancer presents both opportunities for gain as well as the danger of negative consequences. Arthur Frank talked about cancer. He's the Canadian, he's the medical sociologist, and he spoke about illness as a dangerous opportunity. And there is now evidence that breast cancer is a dangerous opportunity for women, that they tend to report growth significantly more than women who have not gone through the trauma of breast cancer. I chose to look at spouses, again, as Arthur Frank says, they're the other half of the illness experience. And in fact, they're now considered survivors in the definition of the American Cancer Society and the National Cancer Institute. We know that they share the initial distress, the symptoms of psychosomatic distress, anxiety, depression, are often as high in spouses as they are in women themselves. So the question was, would they also share some of the benefits? And in another part of the study that I'm not going to talk about, indeed, they share some of the long-term negative and positive consequences. Similarly to women, after the breast cancer, they have to live with the recurrent fear of recurrence, with the constant fear of recurrence. They have to worry about sexual relationship, but they also talk about long-term positive consequences that are very well captured with the post-traumatic growth concept in the PTGI as a measure. In fact, we did a qualitative study and we put away the data because the PTGI really captured the changes quite summarily. So which aspect of the social context should we look at? Again, Rich's model was very useful. The idea is that the social context can facilitate post-traumatic growth and the cognitive processing that yields post-traumatic growth in two ways. The social context can be a source of emotional comfort, and the social context can be a source of new ideas or cognitive schemas. In terms of emotional comfort, the assumption is that the more a person feels loved, supported, cared for, the more likely the person is to sustain the very painful processing of the trauma. In terms of new ideas, it's here the Bandura concept of modeling. The more a person has an example of somebody who's gone through the trauma and has perceived benefit, the more likely that person is to report it himself. Just another emphasis when we talk about the emotional comfort, we need to understand that the social support concept is a multidimensional concept. It really has multiple meanings, and it's important to talk about both the general social support as well as the relationship-specific aspect of the social environment. Want to help me? We can't fit it all. We got some of it. Okay, I'll repeat it. Based on these conceptualizations, we developed four directional hypotheses. One has to do with the general social context. We assume that that post-traumatic growth would be positively related to the general perceptions of social support. The more a husband feels that there are sources of emotional comfort in his environment, the more likely he is to report benefits from the trauma. The second hypothesis had to do with the relationship-specific qualities of the marital relationship. And the assumption was that post-traumatic growth in husband would be related positively to the positive qualities of marital relationship, such as marital support and depth of commitment, and negatively correlated with marital conflict. Third hypothesis had to do with a model in the general social context, and the assumption was that post-traumatic growth in husbands would be positively related to contact with a person who experienced a similar trauma and perceived benefits. And the last one has to do with the assumption that the wife could be a model. Women are known to sustain the cognitive processing longer and to report higher levels of post-traumatic growth. And the assumption was that once the wife has processed the experience and found meaning, she could be a model to the husband. So we tested these hypotheses in a sample of 72 couples. We focused on people who were a year to 5.5 years from the trauma. We did not want people who were in the acute phase of coping with the diagnosis and the treatment. We had people who did not have a previous experience with cancer or other life-threatening disease. We had a response rate of 75%, and we recruited people through multiple sources. We made announcements through the mailings of our support program. We put ads in newspapers. We had referrals from breast surgeons. We ended up with a sample that was middle-aged, relatively well-educated, college-age, primarily Caucasian, and having adequate financial resources and more than that. In this phase of the study, we're talking only about early breast cancer, early stage breast cancer, no metastatic disease. We're talking about women who had either mastectomies with or without reconstruction or lumpectomies, and a variety of combinations of adjuvant treatments. This is the toughest part. Okay, you can't see this. The measures we have used, can you see? Not. Okay. The PPGI, you've heard from Rich. It's the post-traumatic stress inventory. There are 21 items with 5 factors. General social support, we assessed was the SSQ, which measures the degree to which people feel that their sources of support, comfort, reassurance, caring in their environment, and the degree to which they're satisfied with that support. So it yields two scale scores, number and satisfaction. Quality of marital relationship was measured with the QRI. It's a 25-item scale that yields 3 factors, the support, depth of commitment, and conflict. Contact with the model was measured with the simple question, have you had contact with a person who went through a similar trauma and experienced benefits? And we added the measure of the stressfulness of the event. We know that event characteristics are also likely to be related, and there are many ways to measure stressfulness of the event. One way is to look at the degree to which the event met DSM-4 criteria for being a PTSD stressor. So you ask people 2 questions. Have you perceived breast cancer in your wife to be a threat to her life or physical integrity? And have you responded with intense fear or helplessness? Need help? Thanks. So what did we find? We found, as we expected, the general social support was significantly correlated with the experience of post-traumatic growth. The number aspect of social support, meaning how many people in your environment, was significantly related with post-traumatic growth. The satisfaction was not. And there are usually problems of ceiling effects in satisfaction scales. Okay, this is hypothesis 2 about the qualities of marital relationships. As you can see, in terms of the positive qualities, QRI support and QRI depths have been significantly correlated with the total scores of post-traumatic growth as well as with each of the factors of post-traumatic growth. Marital conflict was not related significantly to post-traumatic growth. Okay, hypothesis 3 and 4 had to do with the modeling aspect of the social context, contact with an individual who perceives positive changes. If you can see the mean PTGI of husbands who reported contact was higher than the mean PTGI of those who did not report contact, but the difference was not statistically significant. Wives, however, did seem to be models. There was a significant positive correlation between the husband's post-traumatic growth scores and those that the wives reported. Okay. In addition to the variables that we assessed as related to the hypothesis, we also looked at demographic and event-related characteristics as related to post-traumatic growth. And we found 2 additional correlates in the bivariate analysis. One was time since diagnosis, and it turned out to be negative. There was a negative correlation between husband's post-traumatic growth and the distance in time from the trauma. And the other one was the event stressfulness, and there was a positive correlation. The more the event was perceived as a trauma, or for those husbands that the event was a it was a DSM-4 traumatic stressor, reports of post-traumatic growth were higher. And as if you can see, for 47% of the husbands, breast cancer in wife met criteria for a DSM-4 traumatic stressor. So we ended up with 6 correlates that had univariate relationship to post-traumatic growth. And we put them all simultaneously in a multiple regression. I can't do that, Rich. Okay, thanks. We put them all into a multiple regression analysis. We wanted to find out how much of the variance in post-traumatic growth all these variables would explain. As you could see, we were able to explain 42% of the variance. The 3 predictors that remained significant were the quality of marital relationship in terms of depth of commitment, wife's PTGI scores, and whether breast cancer for husbands constituted a DSM-4 trauma or not. I guess I'm dyslexic about these things. Okay. So what do we make of these findings? Social context variables indeed are related to post-traumatic growth. The fact that social support was, the general perception of social support was related to post-traumatic growth as well as the marital social support are probably indications that acceptance and comfort allow an individual not to have to minimize the trauma and then sustain this painful cognitive processing that ends up with perceptions of positive changes. That marital conflict was unrelated to post-traumatic growth can be explained in several ways. One, it could be the self-selected nature of the sample. We might have gotten the less conflicted, more supportive couples, so the relevance would not be picked up here. It could be a gender issue. Husbands are known to be less reactive to fluctuations in qualities of marital relationships. Or it could be that positive aspects are related to positive outcomes and negative qualities are related to negative outcomes. The fact that depth of marital commitment was the strong predictor in the regression analysis, meaning it was the degree to which the husband felt positive about the wife and about the relationship, rather than marital support or general social support, could be an indication that for husbands what is important is some global perception of the wife, or the degree to which the marriage is a positive part of their lives. And it could be that it's an indication of how much the husband feels that the couple faced the trauma together, and maybe even allowed that sense of security and commitment allowed for greater sharing of the trauma and greater cognitive processing of it. That wife's PTG was a strong predictor is, I think, another indication that wives play the primary role in husbands' lives, even when the wife is sick with cancer. So she still plays the primary role and not somebody else. For women, and we've done some preliminary analysis, the situation is different. And it could be an example of, say, what I would call transmission of post-traumatic growth. We know about the stress contagion phenomenon, and we know that there is contagion and transmission of the negative aspects of stress. This could be an example of transmission of growth. Two other variables, event-related variables, came out as significant correlates. Stressfulness of the event was a significant predictor. And I think that's an indication that Richard's model holds true, that the event has to be of seismic proportions to shatter one's basic assumptions about life and trigger this cognitive processing that yields post-traumatic growth. Time since diagnosis did not come up significant on the regression analysis, but it was negatively correlated. And might indicate, as Rich said, that there's a curvilinear relationship between time and post-traumatic growth. And remember, we only took people a year from diagnosis, so it could be that most of the positive correlation has been missed, and we have only gotten the dip. Which I need help, please. Everything I've said has to be considered in the context of the limitations of the study. We didn't have a very diverse sample. We did not have a representative sample. This was a convenience sample. We have a self-selected group, and the women recruited their husbands. These were self-reports, so we cannot make any claims about objective adjustment. And of course, it's a cross-sectional study, and we can only talk about correlations. We really can't say what comes first. So the implications of the study for future research. I think the study indicates that the PTG model is quite useful for guiding research. I think we need to look at additional factors such as personality factors and the interactions between personality factors and the social context. The picture is probably a lot more complex. And I think Joel will indicate that there are complex effects here. The fact that the marital relationship seemed to be a significant predictor of post-traumatic growth might indicate that other close relationships need to be looked at as well, such as the relationship with adult children. And gender issues really have to be teased out. I would love to see a study of similar nature with men with prostate cancer and their wives, so that we can really see the differences between gender issues and the role of the patient or the spouse. In terms of psychosocial interventions, it's clear that the husband shared the experience of breast cancer both in terms of its danger and risk and in terms of its opportunities. And we really need to offer husbands the support services that we offer to wives, and we need to consider them part of the illness experience. What should we do? How should we do it? Who should we allocate our scarce resources for? If this study indicates that the marital support is a protective factor in terms, at least, of post-traumatic growth, then we may want to think about ways to make that happen more readily and more often. And one way, I talked to a husband who said that his primary difficulty in supporting his wife and her supporting him was the gender differences. All he could offer was problem solving, and all she wanted was validation. So even if we can do a one-time educational piece with breast cancer survivors, we might be able to help them out. And now I'll let you listen to Joel and hear that post-traumatic growth happens in all kinds of people, not just in the higher socioeconomic group or Caucasian sample that I had.